Joel Topf for Nephrology Times. I'm here with Areef Ishani. This is his second interview with Nephrology Times. We're getting a lot of repeat customers today. It's awesome.
That's great.
It's awesome. And you're here at the National Kidney Foundation Spring Clinical Meeting talking about the Dialysis Comparison Project. Again.
Yes.
Again.
Yes.
So last year in Long Beach, you were talking about the kidney outcomes.
Correct.
What do you got for us today?
So again, just to recap, so it's
good. Right. What is the Dialysis Comparison Project? Why don't I ask you, what is the Dialysis Comparison Project?
So just clarify, it's the diuretic comparison.
Excuse me.
No dialysis patients were involved in the study. That's okay.
Yes.
So it's a large, pragmatic, randomized control trial.
Yep.
13,500 patients were randomized.
You didn't say 13,000, did you?
I did. 13,500.
Gotcha.
Randomized to chlorthalidone or hydrochlorothiazide.
Yes.
The overall study demonstrated no difference in cardiovascular outcomes.
Which was the primary outcome. Cardiovascular outcome, no difference.
No difference in cardiovascular outcomes. Last year we talked about renal outcomes. There was no difference in renal outcomes between chlorthalidone and hydrochlorothiazide. And this year we're looking at kidney stones following randomization, comparing chlorthalidone to hydrochlorothiazide.
Okay.
So the reason is, so if you look older, there's a meta-analysis that suggested that long-acting thiazide diuretics, chlorthalidone and dapamide, are better at reducing recurrent kidney stones compared to hydrochlorothiazide. I think there's also a smaller study where they looked at 24-hour urine collections, and chlorthalidone reduces 24-hour urine calcium to a greater degree.
Well, and in the shadow of the no stone trial, where every person who ever took care of a kidney stone said, oh, of course, hydrochlorothiazide doesn't do anything. It has to be chlorthalidone.
Yes.
Right. So this is going to be a slam dunk, right? So chlorthalidone is going to have to be the drug that reduces it.
So every time I come into these, I think this is an easy one.
This one, right? I know what this is going to show.
Yeah, there's no surprise going to show up here. So turns out, as you saw yesterday, there's no difference between chlorthalidone and hydrochlorothiazide in the overall 13,000.
And again, the primary outcome was?
So for this analysis, was kidney stone occurrence. So this is by...
And you do this by chart review. So what if it's on a CT scan? Is that a positive?
So it is anywhere somebody has claimed for it. So it's either a physician goes in and on the encounter says there was a kidney stone.
Yep.
There's a procedure code that somebody went in, smashed some stones, took some stones out.
Yep.
They show up in the emergency department with kind of acute pain.
Yep.
Any of those things show up as an outcome.
So it could be something as simple as they got a flat plate because they had belly pain, and then the doctor documented, oh, there was an incidental kidney stone that gets added to their problem list.
Yep.
That's going to count.
That is going to count.
Okay.
So again, remember, the advantage here is because it's randomized. And all of this nonsense, right? So if everybody's getting flat plates, all the nonsense diagnoses should come out, balance out.
Yep.
And the ones that we care about are the ones that are different.
Yep. Okay.
So overall,
primary outcome?
Nothing.
Okay.
But again, most people aren't going to get the kidney stones. And so
more and more people every year, though.
Yes, indeed.
Yeah.
But the study isn't really designed overall to look at this. So what we did was we did a subgroup analysis.
Okay.
Amongst those without kidney stones at baseline.
And one more, I'm sorry to...
No.
This study was started a long time ago. Are you continuing to accrue outcomes?
We are.
So this is the most up-to-date, the longest follow-up period. Which is,
I should have said that. So the original trial was a median duration of follow-up of 2.4 years.
Yep.
We extended follow-up for this analysis to the end of December 2024.
Oh, wow.
So we have a follow-up of about 4.2 years.
Okay.
And then what we did now is we did a subgroup analysis, a subgroup of a subgroup. Remember, this is a secondary analysis, and now we're doing a subgroup.
Okay, yeah.
And so we looked amongst those with and without kidney stones at baseline. Again, if you have no kidney stones at baseline.
And the same definition that we just talked about as establishes baseline. So if they've ever in the prior to getting started in the trial, the randomization, if they had a kidney stones in their history, boom.
Correct.
Make that a pre-existing stone patient.
Yeah. So the vast majority of the 13,000, it's about 12,500 never had a kidney stone.
So,
right?
Okay. And that rings
low
true
risk
about
population.
10%, but about 10% of them have a kidney stone, which is what you'd expect.
Yeah.
Great.
And in that population with no kidney stones, there's no difference between chlorthalidone and hydrochlorothiazide.
That drives
it's about the same.
Yeah.
Right? It's the one, then you look for a P for interaction, and there's a very significant P for interaction here between, again, randomized by a baseline history of kidney stones.
Okay, so this is getting exciting.
Yeah.
Okay, so now we have a population where there's a signal.
Correct.
which you've been dying to find.
Yes, exactly. Something. Let something be positive. Yes. So the P for interaction is 0.005.
Okay.
And what we see is in people with a prior history of kidney stones, it's the opposite of what we were thinking. Chlorthalidone had an increased risk of subsequent kidney stones. So the hazard ratio is about 1.25, and it's statistically significant.
1.25.
Yeah. So
pretty significant treatment effect.
Right. Negative treatment effect. Yeah, exactly.
I mean,
harm.
You know,
it's a harm.
For being randomized to chlorthalidone. More stones in the chlorthalidone group than the hydrochlorothiazide. So everybody's brain is exploding, but you're going to save us. You can say, I know the reason. Yeah, I know you don't, but give me your thing.
So you see this and you say, well, how am I going to explain? How am I writing this paper?
Right.
I can't write this paper, right? Like, it's worse. Everything I said in the introduction is it should be better.
Yeah.
And now I've got it as worse. And so, we're looking, and so the one thing is that, as we've shown consistently,
from the very beginning of the study,
is that chlorthalidone causes more hypokalemia, right? So it's about a 2% absolute increased risk of hypokalemia, defined as hospitalization for hypokalemia as a primary diagnosis.
Yep.
That's bad. Or a nadir potassium less than 3.1.
Yeah.
And so, it turns out, and I didn't know this prior to writing this paper, is that hypokalemia drives hypocitrate urea.
Yeah.
And so I had forgotten that. It reminded me of that. And so maybe that's the reason, right? So the more hypokalemia drives a low urinary citrate, which then might increase the risk of kidney stones.
That's good. That's good. So that leads to that obvious questions then. Well, so you can look at the patients that have hypokalemia and that don't have hypokalemia.
Correct.
What is that? Have you done
so
that analysis?
We have it. So that's breaking randomization. So what we wanted to do was preserve. So this is a randomized analysis.
Okay.
So everybody's included. So it's intent to treat.
Okay.
And then it's about 13% of people get hypokalemia, and so we haven't done that yet. But that is our next analysis, is looking specifically as hypokalemia as a risk factor for developing.
Right. And that does
stones.
open a can of worms, because I see.
Because now we have to do the adjusted Cox models. It's a different analysis than what we wanted to do for this one.
Well, this is actually super interesting, and it really, this is the kind of thing that really can change how we start thinking about, maybe get off of the urinary calcium and start looking at the serum potassium, right?
Yes, I think. I'm not a big, so I appreciate the 24-hour urine collections and looking at all of these things. But I think ultimately, as No Stone shows, as this shows, is you got to look at outcomes.
You got to look at outcomes.
Yeah,
that's right. Oh, that's amazing stuff. Are you gonna? And I made a joke during your session yesterday, and I didn't mean to make light of it. But are you guys going to look at bone outcomes?
Well, absolutely, right? The advantage of these large pragmatic studies is that you can now use them. You've got the EMR, you've got extended follow-up. So I think we're going to do an extended follow-up for the cardiovascular outcomes, and we're going to look at bone health and things like that.
Samuel Shem, who wrote The House of God, right? He did 1 year of internship and has been living on that year of internship for 40, 50 years. I look forward to you working on the Diuretic Comparison Project for the next decade.
That's the goal. Sounds great.
Dr. Ishani, this was awesome. Thank you very much.
Thank you very much.
Take care.
Have a good day.